On the next video, or on this video, I'll try to explain the various routes of sedation. First, I'd like to discuss various means of non-drug relaxation. Some dentists may refer to this as relaxation dentistry, but it's not sedation dentistry by means of a sedative agent. Some of the techniques are good chairside manners, talking in a low voice, holding an assistant's hand, being kind, using gentle injection techniques, using topical anesthesia, shaking the cheek during an injection, using the wand, using headphones, watching TV, warm compresses, aromatic smells, pedicures, manicures, hypnosis, etc. I think you get the point. Obviously, all of these things do make a difference. A gentle, caring doctor is of paramount importance. You may have seen this marketed as gentle dental. As much as this helps, it's not enough for those of you who need more. You know who I'm talking about if you are one of those. Inhalation sedation. Nitrous oxide is the inhalation gas used in dentistry. It's sometimes referred to as laughing gas or sweet air. There are stronger inhalation agents used for general anesthesia, but not in the dental office. Nitrous oxide does not afford, or it does afford, some analgesia and relaxation. It's a very safe gas. It's not metabolized by the body. In other words, it comes out the same way that it went in. It's very safe to use. Nitrous, when used alone, is at the low end of sedation. When used properly, it will only give a light level of sedation. It works for some people, but not for those with an appreciable degree of apprehension. If used in combination with other sedative agents, it produces a much more significant effect. Oral or enteral sedation is the second route of sedation. This is what most of you see marketed as sedation dentistry or oral conscious sedation. There are actually three means of enteral sedation. Enteral sedation passes through the gastrointestinal system. It can be delivered orally, rectally, or sublingually, or under the tongue. It's usually delivered orally or sublingually. There are pros and cons to its use. The biggest pro is that it is easy to administer. You just swallow the pill. There's a very important concept to understand at this point. There's a thing in sedation and anesthesia that's called titration to desired effect. This means that you can deliver a small amount of the drug until you reach the desired level of sedation. This is extremely important with respect to the safety of the drugs and not overshooting or undershooting the desired level of sedation. If you remember the levels of sedation, the intent of conscious sedation is to never go deeper than moderate sedation. Your intent is to never sedate to the level of deep sedation. Remember the differences between the two. The problem with oral sedation is that you cannot titrate to effect. The drug has to go through the GI system, where it then goes to the liver and what we call the first pass effect. After swallowing the pill, it has to be passed through the stomach to the small intestine. Obviously, it has to go through an absorption process, which takes time. After the small intestine, it's passed to the liver, where the drug is then metabolized to a certain extent. It's then passed into the circulatory system, where it will then eventually reach the central nervous system and reach the brain. Once it reaches the brain, it will then manifest the sedative effects of the drug. Obviously, only a portion of the drug will ever reach the brain. There is a time delay from administering the drug before an effect is seen. The time delay is generally about an hour. An example is the use of triazolam as a sedative agent. It's probably the most common or popular agent used for oral sedation. Other agents, such as lorazepam and Valium, are also used, but triazolam is probably the most popular. The concept is basically the same for all oral agents. Usually a dose of triazolam is given an hour before the appointment. The patient arrives at the office. They're evaluated for their response to the dose given. At that point, a determination is made as to how much more of the drug should be given. This can be a little difficult to determine. If needed, another dose is given. It takes triazolam about 30 minutes before you start to see an effect. It takes 75 minutes to reach its full effect. What if the dose you gave was not enough? Do you give more? And if so, how much? In reality, you need to wait 75 minutes or at least an hour before you will know the true effect of the last dose given. You spend a lot of time waiting. Can you overshoot or undershoot? You have no way of knowing until you see the complete effect of the drug, which again will take at least an hour to reach its full effect. Oral sedation has the ability to take a patient all the way to deep sedation and loss of consciousness. Intravenous or IV sedation is the next route. IV sedation is accomplished by placing an IV catheter directly into the vein. It's usually on the arm, the ventral portion of the hand, could be the dorsal, but it allows the sedative drug to go directly to the brain. There is no delayed reaction due to absorption and metabolism as experienced with oral sedation. You will know generally within 2 to 3 minutes the effect of the drug. It can very easily be titrated to effect. Midazolam or Versed is probably the most commonly used drug for IV moderate sedation. It is the benzodiazepine drug of choice by most anesthesiologists. It's been used for years and it's cleared by the FDA for IV sedation. It will reach its therapeutic effect in 2 to 3 minutes. You will not experience many of the drug reactions with Versed that you will experience with oral sedatives. IV administration of a drug is much more precise and can render a much more effective means of sedation. In fact, I will say it is virtually unanimous that it is the delivery style by oral surgeons as well as dental and medical anesthesiologists. IV administration allows for the more safe, effective, precision delivery of the sedative drug. IV drugs can be titrated. Oral sedation drugs are not titrated, but given in incremental doses. If multiple drugs are given orally, they are stacked, not titrated, with more unpredictable results. I've personally performed about 500 oral sedation cases and 500 IV cases. I initially started with oral before I got my license to administer IV sedation. After performing both oral and IV, I almost exclusively administer IV sedation because of its predictability. I think this is in concert with the opinion of anesthesiologists. I will admit this is my personal bias, but I think it is very well founded. My experience has shown IV the superlative route. At this time, I generally like to limit oral sedation to mild sedation. This way I can keep things safer and more controlled. I can keep things in line with the FDA recommended amount for dosing of a particular oral drug. I understand there are many who use oral exclusively, but it is not my favorite choice for moderate sedation. Other routes of sedation are intramuscular and subcutaneous sedation. They're not commonly used in the dental setting for sedation purposes. I'll see you in the next video for the qualifications for administering various routes of sedation.